I'm Hani Sabour. I'm a consultant cardiologist in Abu Dhabi, and it's a great pleasure to present to you today this very important breakthrough in heart failure, SGLT2 inhibitors in preserved and reduced ejection fraction heart failure patients. These are my disclosures. 100% of the honoraria are donated to charities in the UAE supporting patients. In 2018, Professor Eugene Braunwald, sort of the father of evidence-based cardiology, ventured into the new age of diabetes drugs. And now, 4 years later, we are reaping the benefits. The reason is the initial EMPEREG outcome study that showed us something really remarkable. In a drug that was initially designed for treatment of diabetes, we saw a 35% reduction of cardiovascular death, 35% reduction in hospitalization, mortality, as well as improvement in nephropathy. And in fact, the number needed to treat is 139 patients for 3 years to prevent one cardiovascular death. So 2.5 years of life extended. Now, the key component of this was the massive reduction in heart failure, and this was about 35% reduction in top of standard of care. As we started to learn more about these amazing therapies, we realized that the outcome of reduced cardiovascular event, kidney disease, reduced blood pressure, body weight, and A1C is derived from multiple intermediate effects: cellular, myocardial exchange, inflammation, improved hematocrit, change in afterload and vascular function, and reduced intraglomerular pressure. So ultimately, they're not just diuretics that excrete glucose, but they have direct cellular effects that produce protection of the myocardium and the kidney at the same time. So let's go back to the idea of heart failure, not necessarily congestive heart failure. So heart failure is any structural or functional impairment of ventricular filling, i.e. stiffness and diastole, or ejection, which is ejection fraction and systole. The main manifestation of heart failure actually is dyspnea and fatigue, limiting exercise tolerance. In addition, we are all trained in medical school and residency to look at fluid retention, pulmonary and splanchnic congestion, and peripheral edema. But in the early stages, or the patients on diuretics, you may not have fluid retention. And there are some patients who have exercise intolerance without fluid retention, and others have a lot of edema or fatigue. So congestion is a late phase and not mandatory for the diagnosis. Just to remind you that reduced exercise tolerance, fatigue and tiredness, and increased time to recover after exercise, in addition, avoiding exercise is an important clinical pearl that is misinterpreted in the outpatient setting. Remember to ask the patient directly, can they go up flight of stairs? If they cannot go up one flight of stairs, then it's functional class 2 and they're truly symptomatic. Don't assume if you ask them in sitting in the chair, are you short of breath? The answer might be no. Challenge them because of exercise intolerance as the hallmark and the cardinal sign. Now, remember that reduced ejection fraction is relatively easy. The ejection fraction is less than 40% and patients have symptoms. But mid-range or moderately reduced and preserved ejection fraction a little bit more tricky because here the ejection fraction is normal. So therefore, to qualify, you have to have elevated natriuretic peptides or structural changes like LVH or left atrial enlargement or diastolic dysfunction. So these additional criteria means the echo have to be more carefully interpreted, but natriuretic peptides help you to find the diagnosis. And of course, the new universal definition of heart failure has been around since 2021. Essentially, symptoms and signs, especially effort intolerance, functional abnormalities, and elevated natriuretic peptides, or evidence of congestion. Now, in the outpatient setting, the diagnosis of heart failure using natriuretic peptides is totally different than what you have in the acute emergency room. Actually, if you're using NT-proBNP over 125, for the acute heart failure setting, a cutoff point of 300 is recommended. And this is also age dependent. So remember, it's a much lower cutoff point to include heart failure in the outpatient setting. Now, the important point is that if you look at the stages of heart failure, the progression of heart disease, so patients with hypertension, diabetes, and obesity were patients in the EMPEREG outcome study. They were all diabetic patients. And in fact, all of them had some sort of cardiovascular disease. And here, EMPEREG showed reduction of heart failure, prevention of heart failure primarily. Now then you have stage B, which is pre-heart failure. So patients with LVH, patients with wall motion abnormalities, patients with abnormal diastolic function or natriuretic peptide. Here, overlapping with EMPEREG preserved because some of these patients have to have minor signs as well. And then as the system progressed, you have more emperor-reduced type patients, which were patients with reduced ejection fraction, LV dysfunction. So it's a spectrum of severity. And with guideline-directed medical therapy, you can actually reverse this and make the heart failure improve. So remember now that emperor preserved and emperor reduced now, which have been published and now actually incorporated in the label and the package insert, means that you can use it in all stages of heart failure. So LV ejection fraction is actually not the most important component of the heart failure definitions, because now you have from ejection fraction of less than 40 to 40 to 49, more than 50, or improved ejection fraction. The new classification covers essentially all of the stages of heart failure in patients with symptoms. And now we have emperor showing evidence in all of the stages as well as prevention. So to make this more clear, the ejection fraction decreases with progressive remodeling. The ejection fraction can be improved with guideline medical therapy, CRT, or revascularization. So you have to look at where the therapies are indicated. And now with the advent of emperor preserved, in addition to emperor reduced, we have essentially the entire therapy spectrum covered with evidence-based medicine for improvement. Now, the important thing to also remember that the SGLT2 inhibitors, all of them, Emperor, Canvas, Declare, Credence, and Vertis, actually showed prevention of heart failure in the primary diabetic population with cardiovascular disease. In fact, in the original studies, only 10 to 14% of patients actually had known heart failure, yet almost a 40% reduction of new onset of heart failure, preventing heart failure from happening in the first place, is the guideline now for SGLT2 inhibitors. Now, one of the important things that we have always been trying to attend to is what diabetic patient needs heart failure treatment or is at risk for heart failure. Well, it's diabetics with renal impairment, diabetics with proteinuria, diabetics with LVH. Those are the very high-risk patients, and they're not only very high risk to develop cardiac events, they're also very high risk to develop heart failure as well. Remember, again, that the Emperor, Canvas, and Declare study, less than 10% of these patients had reduced ejection fraction, and heart failure was reduced in significant numbers, 40%. So most likely these were HFpEF patients that were not recognized. So as we have gone from the treatment of diabetes with SGLT2 inhibitors to now the treatment of non-diabetics with SGLT2 inhibitors, we now have DAPA-HF, DELIVER, Emperor preserved and reduced, all published. Also now we have EMPA-KIDNEY and DAPA-CKD in diabetics and non-diabetic patients. So it's an amazing development with drugs that really have impact on 2 or 3 significant diseases in diabetic patients. Now, just to tell you the burden of heart failure in our metabolic patients is that 2 important studies looking at relatively asymptomatic patients with diabetes using echo or echo and BNP, actually the majority of patients using echo alone, 68% of these patients had either diastolic or systolic dysfunction or both. Using ECG, echo, and BNP, undiagnosed heart failure was detected in 28% of patients during cardiac screening. So it's extremely common, and it now has the name of metabolic inflammatory cardiomyopathy, where pre-diabetes or diabetes, metabolic syndrome, inflammation, fibrosis, and stiffness are all resulting in heart failure with preserved ejection fraction, but the largest component of those patients numerically are actually diabetics with metabolic syndrome. And I want you to consider this important point. In the SGLT2 inhibitors, the great outcome on heart failure and heart failure by ejection fraction reduced or preserved was not known at that time, right? It was a completely new concept. And we found that in these patients where the EF was reduced, there was a 38% reduction. In the preserved, a 12% reduction in heart failure. In Canvas, again, 17% in HFpEF and 31% in HFrEF. So what are the learnings we have from the RCTs and the guidelines? In reality, in diabetic patients, there is no reasoning or evidence to withhold SGLT2 inhibitors in any patient at any stage of the disease. You should really never withhold SGLT2 inhibitors in diabetics with risk factors. It's more dangerous to withhold SGLT2 inhibitors in diabetics with complications of the disease, such as heart failure, renal failure, or cardiovascular disease. This would be like withholding a statin in a patient with coronary artery disease or not giving aspirin in a patient with MI. If you think your diabetic patient needs a statin, they actually need an SGLT2 inhibitor even more. It's the same risk manifesting in 2 different organs. It's a universal multi-organ protection, greater even than statin use in both primary and secondary prevention. Because you know that they reduce MACE and ASCVD MI patients from EMPEREG, they reduce CV death in diabetics with CKD, even with very low GFRs, they reduce heart failure in patients without recognized heart failure. Now we know that they also reduce heart failure in patients regardless of ejection fraction or even prior heart failure. They reduce CKD even if the GFR is early, above 85. We also have reductions in hospitalization, dialysis, and healthcare costs, amplified in diabetics, but also applicable in non-diabetics, as we've seen in EMPEROR-reduced, EMPEROR-preserved, and in the kidney studies. And finally, all of this regardless of A1C in diabetics and non-diabetics. So the cardiorenal axis here is actually amplified and protected by SGLT2 inhibitors. What is good for the kidney is excellent for the heart. What is good for the heart is excellent for the kidney. And this is something unique to the SGLT2 inhibitors. So just to remind you of the EMPEROR reduced outcome study. Over the course of the study, there was a 5% reduction of CV death or hospitalization of heart failure, a 25% relative risk reduction, and number needed to treat of only 19. The other endpoint was recurrent heart failure, first and recurrent heart failure. Obviously, the heart failure patient comes multiple times. Here we got a 30% reduction of heart failure events compared to placebo. And the other remarkable thing is that in these sick patients with low ejection fraction, poor renal perfusion, empagliflozin reduced the worsening of kidney function and caused an improvement of kidney function at the end of the study compared to placebo by almost 1.7 mLs per minute per meter squared in GFR. So it's a very important measure protecting the kidneys. So that was the primary and secondary endpoints in the EMPEROR-reduced outcome study. When you compare EMPEROR-reduced and DAPA-HF, you find that together, both reduce CV death or hospitalization. CV death as a meta-analysis, of course, there's a slight difference in the studies, again, is strongly positive. And in fact, if you look at the data for SGLT2 inhibitors in patients with CKD 1, 2, and 3, the data is extremely strong on top of ACE, ARB, ARNI, and beta blocker for cardiovascular protection and renal protection in patients with both CKD and heart failure, a very powerful combined protective effect. So the next point is the EMPEROR-preserved study. So the EMPEROR-preserved looked at patients with heart failure and preserved ejection fraction. EMPEROR-preserved looked at a very common phenotype. More than 50% of patients with heart failure have HFpEF. The number is increasing, and 30% of these patients die within 1 year. And this is from recent evaluations from Framingham, almost a 15% increase in HFpEF over the last decade, with a reduction in HFrEF due to important treatments like ICD and CRT. So of all of the studies in mid-range and preserved ejection fraction, only the EMPEROR-preserved study achieved this primary endpoint robustly without any questions. TOPCAT, Paragon, CHARM-preserved, and PEPC-HF actually just failed to meet the primary endpoint but met secondary endpoints. So this is a unique study design that looked at patients with EF 40% or more and elevated NT-proBNP, and they looked at patients with and without AFib, and also the definition, as I said, increased left atrial size, left ventricular mass, increased BNP, or a heart failure admission within 12 months. So very clear clinical endpoint. And they included a lot of different regions. The ages were obviously older. That's the HFpEF phenotype. The EFs were primarily above 50%. So from 50 to 60 and more than 60 were almost 63% of the study. Elevated BNP, ischemics and non-ischemics, and functional class 2, 3, and 4, all ambulatory patients. Now, if you looked at the GFR, a lot of these patients had a reduced GFR, almost 50%. Actually, half the patients were, less than half the patients were diabetic. And all of these patients were on RAS blockers, neprilysin inhibitors, MRA, beta blockers, so very robust background therapy. Compared to Paragon, CHARM-preserved, and TOPCAT, these were really sick patients. They had a more LV hypertrophy. They had elevation of the BNP higher than the other studies, and the GFR was somewhat the same as the other agents. But unlike the other studies, there was a very powerful 21% relative risk reduction and a 3% absolute risk reduction of heart failure or CV death, number needed to treat 31, and very clear separation of the curves. Now, whether the patients were male or female, diabetic or non-diabetic, older or younger, obese or non-obese, CKD or no CKD, there was a tremendous outcome advantage. All of the subgroups are actually towards the empagliflozin side, whether using ARNI, ACE, ARB, EF was not important, no p-value for interaction. So very important to realize that every kind of patient benefits. Now, recurrent heart failure, frequent heart failure admission is very important to the patient, 27% relative risk reduction. And in these patients where the GFR was predominantly about 60, again, these patients had a tremendous advantage in protection of their kidneys and prevention of worsening of renal function. 50% difference compared to placebo. So all of the endpoints were met. CV death or heart failure hospitalization, recurrent heart failure, and protection of the kidney, very advantageous. And looking at the specific components of the endpoints contributed to the positive endpoint. The functional class and what we call KCCQ and hospitalization, diabetes, all importantly improved. And this is a KCCQ. This is actually a quality of life validated questionnaire, significantly better on empagliflozin, either on treatment or intention to treat. And in fact, almost a 30% improvement compared to placebo. So the patients obviously feel better and they report that. Functional class, remarkable difference by the end of the first year, significantly better than placebo in terms of functional class. Now, naturally, in patients, there was an improvement of their hematocrit. There was a slight reduction of the body weight, about 1.5 kilos, reduction of the BNP, and reduction of glycohemoglobin in diabetics. The safety outcomes. Again, a lot of these patients are non-diabetics. In fact, serious adverse events were numerically less in the empagliflozin arm. Hypotension was the same as placebo, no statistical difference. Acute renal failure was reduced. UTI was not significantly different, and genital infections were not significantly different either. Now, hypoglycemia and ketoacidosis were no different in diabetics and non-diabetic patients compared to placebo. So clearly these agents do not cause hypoglycemia. So the safety is all the way down to a GFR of 20, very safe in HFpEF patients, no hyperkalemia, no hyponatremia, no acute kidney injury. Across the heart failure spectrum, functional class 2, 3, and 4, with or without prior heart failure, ischemic or non-ischemic, NT-proBNP, high, medium, or low, male or female, with and without CKD, with and without diabetes, even in a patient with an ejection fraction over 50%, and achieved the clinical benefit within 18 days. Very quick response in every kind of HFpEF patient. And if you put this in overall context, and this is a very nice comparative publication, looking at the benefits in SGLT2 inhibitors. So these here on the left side are the outcome studies. And basically you get about a 2% absolute risk reduction with Credence, Vertis, EMPEROR, Canvas, and so on. As you go up to EMPEROR Preserved, you get about a 2.5% absolute risk reduction. If you go to sicker patients, which is EMPEROR Reduced, much sicker patients, lower ejection fraction, 6% absolute risk reduction. And SOLOIST, which was the acute worsening heart failure, almost a 14% total and recurrent events. So very powerful across the entire spectrum, from prevention to treatment in Preserved to treatment in Reduced, very powerful outcomes. So we got a 21% in the primary outcome of CV death and hospitalization. Renal outcomes, what's good for the kidney is good for the heart and vice versa. Very powerful safety profile, no difference than placebo, and the entire heart failure spectrum, regardless of ejection fraction, was covered. Now, very briefly, I'm going to cover EMPULSE. So EMPULSE is another very powerful part of the EMPEROR program where they looked at acute heart failure patients. So we've taken the chronic heart failure, now we're going to look at acute heart failure. A smaller study, basically the patients were admitted and randomized within the first 3 days, and they looked at death, heart failure events, and quality of life questionnaire. Again, these are patients admitted to the hospital, either de novo or decompensated, randomized within 24 hours. BNP, of course, in the acute heart failure is much higher, 2,400 if you have AFib, NT-proBNP 1,600 if you don't have AFib, and they require treatment with loop diuretics for a single dose or more. They had to have dyspnea, they had to have signs of decompensation, congestion, so clinically relevant heart failure. Now, they had to be stabilized first before enrollment, so there are no inotropic drugs, no vasodilators like nitrates or nitride, and the diuretic dose had to be stable. Now, they looked at many endpoints, all of them relevant heart failure endpoints. Without going into the details, the time to death, heart failure, frequency, and quality of life. Of course, these are the typical acute heart failure, frequent flyers, older. There was a good number of females here. All the races were represented. Functional classes, of course, were more advanced, 3 and 4. Very high NT-proBNP, 3,000 as opposed to 900 in the chronic stable heart failure patients. And the BMIs were, as you see here. Now, the GFR was typically around 50, but actually 27% of these patients were below 30. More advanced patients, sicker, decompensated diabetics, again, half of the patients, not the whole number. And the background therapies were ACE, ARB, ARNI, 90%, MRA and beta blockers. Very powerful background therapy. What was the outcome? Very important. The overall clinical benefit using something called the win ratio, significantly in favor of empagliflozin, superior in 53% of patients. Time to death, again, in favor of empagliflozin delays, time to death, heart failure frequency, and the functional class assessment were significantly better. If you look at the empagliflozin in terms of new or decompensated heart failure, diabetics and non-diabetics, age, absolutely no difference in terms of the groups. All the subgroups benefited. And if you look at the BNP or the ejection fraction, this is acute heart failure now, above 40 or below 40, again, all the patients had a benefit. And of course, again, protection of the kidney. We have the initial GFR dip, and then the kidney function over the 90 days of the study actually gets better with the empagliflozin. Adverse events, no difference. Hepatic renal failure was actually improved, acute renal failure. Volume depletion and symptomatic hypotension, no real difference compared to placebo. So there was a real and significant reduction of acute renal failure with empagliflozin given in the acute setting. So the conclusion is 36% more likely clinical benefit with empagliflozin in the acute setting, consistently in heart failure or preserved or reduced acutely, decompensated or de novo, well tolerated with safety data considering the prior outcome studies. And I think I'm going to close with this very important statement from Professor Eugene Ronbrold. So in 2018, he told us we're going to start using these medications in heart failure and other conditions. Now he has come up with this beautiful editorial, SGLT2 inhibitors, the statins of the 21st century, because they protect heart failure in diabetics, they treat preserved and reduced ejection fraction heart failure in diabetics and non-diabetics, they protect the kidney in both situations, and we now have multi-organ protection across the board, across the spectrum in the chronic and the acute heart failure setting. And therefore, my dear friends, we really need to think about any patient not receiving these agents. Why are they not receiving them? And why are we protecting them from life and organ saving protection? And thank you very much.